Hello and a very good evening to everyone watching us here. We are back with another Covaxin Chronicle webinar on our usual Sunday evenings exclusively with Docplexus. I have been joined by Dr. Khusrav Bajan, who is a consultant critical care specialist and the head of emergency medicine department at Hinduja Hospital in Mumbai. Dr. Bajan has a fellowship of the College of Critical Care Medicine of India. He has co-authored many books and publications like Textbook of Emergency and Trauma Care published in 2017 and Signs and Symptoms in Clinical Practice published in 2019. Dr. Bajan is a gold medalist in the first certificate course held by the Indian Society of Critical Care Medicine back in 1999 and a pioneer in bringing the American Heart Association run BLS and ACLS courses to India. Dr. Bajan is a recipient of the Lifetime Achievement Award in Emergency Medicine in India. Apart from this, he is also the recipient of the Times Healthcare Award as Legend in Critical and Emergency Care for the year 2018. Apart from this, Dr. Bajan is a task force member of the Maharashtra state for COVID. We shall be discussing about Delta variant, a highly transmissible strain of SARS-CoV-2, which was first identified in India in December and rapidly spread across many other countries, leading to a big rise in the number of infections. So in this webinar, Dr. Khusrav will be talking about how dominant the strain is, how effective the vaccines are, and going forward, what can we learn from this experience? So without further ado, I would like to invite Dr. Khusrav Bajan to speak. Welcome, sir.
Thanks, Darshika. Can I have my slides shared?
Yeah.
It's indeed a pleasure to be on this platform and reach out to more and more people for a good, fruitful discussion.
Yeah, I can see your slide.
Is it fine? Yeah.
Yes, sir.
Hello, friends. We know that the COVID pandemic has devastated the world over the last 1.5 years. And as we have been grappling through it, we just have a sudden burst of the variants, and I would call it enter the dragon or enter the variants. And we, to just add insult to injury, and we now will just talk for the next 15-20 minutes and then take all questions, which I think I could try and answer best, about the Delta variant and its effects on the community. We know that the COVID scenario has been dismal. It has been a menace and a demon. It has been an unknown enemy. It has caused mayhem worldwide. It has led to a lot of loss, grief, depression, even the economic and social crisis, to just name a few, exposed the inadequacy of the pre-existent healthcare systems worldwide, made us realize more and more what does not work, like ivermectins and hydroxychloroquines, etc. Early recognition, early hospitalization, oxygen, steroids, and of course vaccinations have helped us in containing the virus and its deadly effects. Just when we thought we knew enough, the world was again hit hard by the variants, and especially the Delta, which led to a lot of unknowns, uncertainties, and a sense of panic yet again. So what are the variants and what do they actually mean and how do they occur? Variants are basically a change in the virus structure due to mutations on the spike protein or the receptor binding domain, making it a stronger and probably a more evasive virus. This basically follows the Darwin's law of survival of the fittest. We have over decades spoken about the bacteria becoming resistant and causing a problem in sepsis and killing millions and millions across the world. Bacteria usually mutate because of a selection pressure and a misuse of antibiotics. And the more they are exposed to an antibiotic in the wrong way, they will definitely mutate and become more resistant. Similarly, the COVID virus, whenever allowed to infect people all around the world for a longer time, now it's been 1.5 years and more, it allows itself to replicate tremendously and then causes a coding error, and that leads to a mutation or a virus, a variant. These are then detected by the genomic testing and the use of the pango lineage known as the pangolin. And for example, we've had the B117, we have had the B16.7.2, which is the Delta, the P.1, etc. So the evolution of the variants worldwide was starting from the wild type in Wuhan, and then they were labeled as the Kent variant and the South African variant, the Brazilian variant, the California variant, and the Indian variant, because it's supposed to have originated from these areas. The WHO, for once, decided to avoid the stigmatization of the countries and have an easy nomenclature, and hence resorted to the Greek terminology a few months ago. They divided these variants into the variants of concern and the variants of interest, and then a third category, which is variants of high consequence, but none has been yet involved in this third category. So how do we decide which variant, or at least the WHO decides, which is a variant of concern and which is a variant of interest? So there could be, due to the mutations, the variants could have an increased transmissibility and therefore infect more and more people worldwide, cause severe disease probably, and lead to an immune escape, leading to false negatives. The RT-PCR may turn out negative and the patient would have full-blown COVID. It may also decrease the antibody response. The cocktail that we have been using and found effective might be rendered useless. And then there is a theory that it might decrease the vaccination efficiency. And when there is evidence and data to suggest that any one or a few of these is existent in a particular variant, then it would be labeled as a variant of concern. And if there was only an association and not much evidence, it would become a variant of interest. So of the various variants that we've been talking about, we now will talk about them in the Greek terminology. So the four variants of concern are the alpha, which was the B117, the UK strain, beta, that is the B1351, South African strain, gamma, the P1, Brazilian strain, and then the delta, B1617.2, that is Indian strain. Again, I'm sorry, we should not be mentioning these countries, but this is just for us to understand. The idea of this terminology was to take away the country of origin. The the variants of interest are the kappa, the lambda, which again came from Peru, the epsilon, and then the zeta, eta, iota. But the zeta has now been degraded and it is neither a variant of interest anymore. We recently in the newspapers had this in Mumbai. Why Delta remains #1 threat amongst all the coronavirus variants. And this is a very nice article which actually looked at, if you can see here, how rapidly the US and all across the world the Delta has been spreading. Initially, it was only responsible for 5%, and as of today, it is responsible for 83% in the US and almost 85% in the UK and 90% in India as a strain of the current etiology. There is another way in which they have addressed this article where they have said that the Delta variant remains to be a super spreader, not the events, but the variant itself. And as you can see here, it's not very clear, but the transmissibility gets a 4+ and the immune escape gets a 2+. There is not much data on this, but we will talk about that in a bit. And then it also talks about how contagious, how one infected person can infect the others is all mentioned in this lovely article. So what about the Delta variant? Yes, it did arise in Maharashtra, India. It is the double mutant. And why? I promised I won't talk about all the genomics here because it's very difficult for even me to understand. But I would do this just for the Delta with a purpose. So it has got two mutants, and that is the E452R and the E484Q. Now this E452R is the same found in the epsilon variant, and this is responsible for the increased transmissibility. Whereas the second one, that is E484Q and R, is the same found on the gamma and the beta, and this is responsible for the immune escape and thus the breakthrough and the reinfections that we are seeing in the current scenario. So initially, it started off with one country, and as of today, there are more than 104 countries which are affected by the Delta variant. It has been responsible for the second wave in India and the second and third waves in many, many other countries, especially the UK and now the US. So let us address three things about the Delta variant. Is it more transmissible? Is there an increase in the severity? And third, what is its effect on the vaccines? And then I would be happy to take any questions from the audience. So we need to understand when we talk about transmissibility as the R0, that is the RO fraction. When the wild type was found in Wuhan, it had a transmissibility or an R index of 2.5. What does this mean? What do you mean by the RO? It means that one infected person can infect 2.5 times by the wild strain, 4 to 5 times or 4 to 5 people can be infected by one person in the alpha strain, and 5 to 8 can be done by the delta. And if you compare this with even the smallpox, which was the most contagious at its time, it had an RO of 4, making the Delta variant extremely transmissible. The UK study within a month back showed anything from 30 to 100% transmissibility, and a CDC guideline or a study just 2 days back showed a 60% increase in the transmissibility. So this is going to spread like wildfire. A Chinese study in June of this year showed that the viral load was 1,000 times higher in the Delta affected patients. This would obviously mean that it is allowed to replicate faster and more, and this again would lead to some other variant happening in a few months, more infectious, and making it and having an immune escape mechanism. So yes, by these slides, we have understood that it is at least 60 and even more % transmissible than the previous variants. Coming to the second part, and that is, how does it present differently, and is it more severe? So what if it transmits to more people? Is it severe, and do we need to worry? So about the presentations, yes, we also noticed it in our second wave. There was less of cough and less of the upper respiratory tract symptoms. There was more of headaches, there were more of GI symptoms, and the symptomatology did differ. Adding to that, there was the RT-PCR, which may have turned negative because, again, of its immune escape mechanism. Is it more severe? Yes, it is. It has affected early and rapid lung involvement in many patients. Younger age group patients may have led to myocarditis, and this data is a little less, but we have enough data to show that it has led to more need for hospitalization and the more increased need for oxygenation, leading to an oxygen debt and crisis sometime just in the second wave, which India and many other countries faced. A Scottish study in the Lancet studied around 20,000 infected patients and found that there were 377 who needed hospitalization, and they said that the risk of hospitalization is totally doubled with the Delta variant. So yes, so far we've understood that it is highly, highly transmissible, and yes, it is doubly severe. Before I move on to the effect of the Delta variant on the vaccination, let me talk about the worldwide inequality, unfortunately, that we see in the vaccination programs. As you can see, the light green is those who have been vaccinated only with one dose, and the darker one, which is here, is the ones who have been fully vaccinated with 2 doses. So you can see that UK had, and this is as of July 22, and that is just 2 days ago. So if you can actually look at this chart, you can see that in the UK, which tops the list, you had 54 fully vaccinated plus 15% of partially vaccinated people. If you compare that with Bangladesh, it is just 2 or 3%. And India, we have about 24 to 25%, of which only 7 to 8% have been given only 2 doses and 18% have been given 1 dose. Let us look at some data which was very recent in Mumbai. So this is a very, very nice article again, and therefore I've just pulled it out for discussion. Mumbai vaccination chart. 90 lakh people are the city's total eligible population. So we have a population in Mumbai of 1.2 crores. The other 25 to 30 lakhs are children and below the age of 18, and therefore we didn't take them into account, at least for now. Out of the 90 lakhs, 35 lakhs lakh people are over the age of 45, and 55 lakhs, about 2/3, is above the age of 18 to 45. Vaccines delivered, I won't go into major details, but vaccines delivered were a total of 15 lakhs in the 60 and above population, 19, almost 20 lakhs in the 45 to 60 population, and 23 lakhs in the 18 to 44 population. This gave us an 88% or 89% of senior citizens having got at least 1 shot, and nearly half of them getting fully vaccinated, being the vulnerable population. So we have basically given 1/3 of our shots in Mumbai compared to the 1.8 crore doses that we needed. We have utilized about 65 and given it appropriately. Now this is about 10 days back, and therefore this is counting. How does now, coming back to our topic, how does the Delta variant affect the vaccination? So there was again, and I would be mainly talking about India, but also the worldwide. So in India, we had a recent study from Hyderabad, which looked at 1,161 hospitalized patients, of which 495 were vaccinated and 666, so 40-60 ratio, were unvaccinated. This study found the Delta variant to be present in more than 90% of the samples studied in both the groups as per the genomics. So major cause of concern in the second wave has been Delta variant to more than 90%. The others were probably Delta plus and a few others. The vaccinated group did find an increased level of neutralizing antibodies and a decreased level of ferritin and LDH, indicating that even if the Delta variant affected the vaccinated people, it was not very severe. And this is an amazing chart, which is an eye-opener. They divided the vaccinated and the unvaccinated groups. They divided and looked at 3 categories. One was which one had a more severe disease. And yes, this is all concerning only the Delta variant. And they realized that the vaccinated had a 3.2% severity index, whereas an unvaccinated had a 7.2%. So more than double in the unvaccinated group. Requirement for ventilatory support, despite having elderly and comorbid patients in the vaccination group, was nearly half. So it was 2.8% in the vaccinated as against 5.9% in the unvaccinated. And look at the mortality. If a person was unvaccinated, then the mortality was 3.45% in this study, and it was 1.5% in the fully vaccinated group. So very, very few patients who do get infected, who may have a severe disease, die. So less than 1.5%. And is 1 dose enough against the Delta? And evidence has shown across the world and in this study that no, 1 dose is not sufficient, and that would give a mortality of 3.35%, almost the same as the unvaccinated group if only 1 dose was delivered. Either the vaccine, so 90% of these patients received Covishield and 10% received Covaxin. There is a recent data similar to the Hyderabad study from the ICMR, and this is also very rewarding. It says that if a person is fully vaccinated in India, 9.8% only needed hospitalization, and only 0.4%, less than even the previous study, died. And this is the latest, just yesterday's article by the CDC in a California study, which says that 83% were infected by the Delta in the United States, and counting, and I'm sure this is rising by the week. But this is the most important data. 97% of COVID hospitalizations and 99% of deaths found amongst the unvaccinated group. So again, if you are fully vaccinated, you are very, very well protected, even against the Delta. So I would just like to end here by a message across to all my fellow colleagues and friends. We must follow CAB, and that is COVID appropriate behavior. We must continue to do hand washings, keep our social physical distancing of minimum 3 to 4 feet or 1 or 2 meters if we can, masking even after full vaccination. Avoid the super spreader events like political rallies, marriages, conferences, religious events. Say no to vaccination hesitancy because we have data to prove that it works even against the variants. More equitable vaccine distribution worldwide, and that the WHO, CDC needs to decide on a bigger front. And then finally, stop the virus and stop the variants and be safe. So this is a very nice cartoon where this coronavirus or the other previous variant said that just when they thought they had us beat, we are back with a Delta variant. But we would never give up, and we will take care of whichever variant has to come by preventing it and handling it with caution. Thank you. So I'm absolutely ready to take any questions if you all have.
Thank you, Dr. Bajan. Thank you for such a great talk. We have a lot of questions for you. So moving on to the questions. The first question is, we have several questions on whether we would require a booster with the current vaccines to deal with any new variant coming in the future.
Yeah, so basically, we are not going to need any boosters as of now, and it will be very unfortunate to, I showed you the inequality of the vaccination programs. So those who have already got enough vaccinated, their population vaccinated, they would want the third booster, but that would be very unfortunate because there are many others who've not even got their first or second. So giving a booster is out of question in my view. Secondly, there will be some tweaking up of the vaccinations in the years to come or the months to come. And that is because the virus has mutated. So we need to cover it with a better vaccine in the future. So there is work going on in that. There is work going on even in the children age group or the child age group. And therefore, vaccinations is an ever evolving technique.
Thank you so much, sir. We have one question from Dr. Kumkum Bhattacharya. She says, what are the diagnostic strategy of Delta variety and prevention? I think what she wants to say is Delta variant and prevention.
Yeah. So diagnostically, as I said, if you do the regular RT-PCR, you might miss it and you might want to persist if the patient has all the symptoms of COVID, and preferably treat the person as COVID unless proven otherwise, even if you have an RT-PCR negative. Having said that, to know the variants, you need genomic testing. And initially, we had very, very few genomic labs, but now we are increasing them by leaps and bounds. And we have not reached our desired level. But yes, we are doing more and more genomic testing, and we need more data.
Sure, sir. So the next question is from Dr. Gupta, Purushottam Gupta. He asks, what are the new guidelines issued to combat the spread of Delta variants?
So there is no different guideline for the Delta variant or the Lambda or the Kappa, which have also come after the Delta. Basically, your COVID appropriate behavior, your masking, maybe even double masking, but I don't think that's feasible sometimes. Also, you might have to keep washing your hands, though we know that there is not so much evidence on fomite transmission of the COVID, but yes, we have to keep our hands clean with the alcohol-based rub. The reason is that at least when you're touching the mask or putting the mask on or taking it off, you need clean hands. And your social distancing or physical distancing, as I say, of at least 4 feet. Avoid closed spaces, and that is very important. So lifts are bad. Bathrooms are bad because you don't know if a positive patient has used it before. And any AC ventilation is also bad. So cars, lifts have to be avoided. Open spaces are the way to go.
I think that brings me to the next question, which says, will there be a different recommendation around the non-pharmacological interventions that have been recommended? For example, that you mentioned physical distancing. Given the Delta variant is highly infectious, will be different in the recommendations?
No, so we need to understand that we need to vaccinate ourselves first and fast. So whenever you get a chance to get vaccinated, please get yourself vaccinated, get your parents, friends, kids, whoever you have vaccinated as early as possible. Also remember that if you are vaccinated, there may be a theoretical possibility that you might infect somebody if you have contracted it earlier for a few days. So make sure that you keep a very close vigil for your own symptoms, and please vaccinate. Otherwise, there is no difference depending upon the variants, and you need to be very, very mindful of what you are dealing with.
Sure, sir. Another question is, could you talk about reinfection in terms of different variants?
Yeah, so all the reinfections that we have studied, as I mentioned, the article, that was a reinfection mostly. And in the reinfections, we have realized that it is because of the Delta variant. So, and also it is seen more commonly in the healthcare workers. So those who are exposed mainly to the patients with COVID and are working as the frontline workers, that is the doctors, the nurses, the healthcare workers, the housekeeping, etc. They definitely are more and more exposed to the COVID patients, and they are likely to get reinfected. The reinfection could be because of a bubble that we have made in our minds that if I'm vaccinated, I might be go at ease and I might not get infected again. And therefore, it leads to lowering your guard very often, even as doctors, when they are eating together in a canteen or etc. And also the excessive load that viral load that they are given through the patients and contact. So I think this is reinfection is on the rise because of the variants, because of the false security of vaccination, and presuming that you don't need to wear your masks anymore, and also the viral load in a specific group of patients, that is the doctors, the nurses, the healthcare workers.
So since you are stressing so much on the vaccination, I think we have another question from Dr. Arora, who says, why don't we vaccinate door to door?
Yeah, so at least in Maharashtra, we have come up with the task force guidelines, and the government has decided to start vaccinating even at home for people who cannot come to the center from the 1st of August.
Okay, that's a good news. Moving on, we have another.
It's not logistically easy, because many a times a certificate given may be false and people just want others to come in. Secondly, the vaccine, if once opened, needs 10 people to be vaccinated. Right. It all depends, and it's not logistically easy, but we have decided to do it from the 1st of August.
Thank you so much. The next question is, how frequent do you get a positive antibody result after COVID vaccine of people using long-term steroids? And if they are antibody negative, how can they be protected?
Right. So it's an interesting question. First, I would say that do not check your antibodies after being vaccinated. You just presume that you are vaccinated. You are safe against a very severe disease, but you're not safe by from contracting it again, getting reinfected, and not at all keeping your friends and other people safe, because you might contract it, have an asymptomatic, be an asymptomatic carrier or a symptomatic, asymptomatic carrier, and give it to others. So please do not do your antibodies and follow the right protocol. Yes, elderly people and patients on dialysis, patients who are immunocompromised, renal failure, those who are on steroids, do not mount. There is a study which says that elderly people and this group of patients do not mount the same antibody response as a younger individual after the vaccination. But there is enough evidence to say, please do not check your antibodies.
Sure, I think that answers the question well. The next question is, apart from wide vaccination coverage, wouldn't early antiviral treatment of COVID cases reduce the infectious population and thus cut down the transmission more effectively?
Yeah, so all the antivirals, the monoclonal antibodies which we have been using, though they are very expensive, are used in the hospitalized patients or those who are in the OPD, at least the monoclonal antibodies. So this can be used to treat a patient, and it definitely reduces the severity, might decreasing the length of stay, which has been shown with intravenous, and now there is not much evidence on the oral antivirals, but yes, we do use IV antivirals whenever a patient is admitted in the hospital.
Sure, sir. The next question is, in an expert perspective, what are the best effective strategies and techniques to create a global immunity of the virus, and what is the process to reach there?
The only way is vaccinate yourself early, and please use COVID appropriate behavior, which includes the three: wash your hands, wear your masks, and keep your social distance.
Sure, sir. Another question is, so I think you did mention about genome sequencing. So what's the role of genome sequencing expansion efforts here? And do samples go under genome sequencing?
Yes, so they do, and there is an increase in it. I am not the expert, but yes, we have increased our sample collection from public and private hospitals, and it's much easier. We just fill a form and we send it across. So there is data which is evolving in healthcare workers who are reinfected, and even patients who had the second wave affecting them, where we have increased our genomic sequencing, which was less than 1% in India. And the desired is at least 10 to 20, 15%, and we are almost reaching there, hopefully.
Correct. So any suggestions for improving the surveillance system in our healthcare departments to deal with such mutating virus?
So testing and tracking and containing is the main way to go. And that's again a very good question, but this is becoming more and more on the COVID. As a pandemic, this is very important because the government needs to do more and more tests. We need to, after doing the tests and those who are positive, we need to definitely collect them and trace them, and at least 20 to 25 contacts of them that they have come in the past few days. And all of them, wherever there is a hot spot, we need to contain them. So micro containments, testing and tracking is the way to go.
Thank you so much. Moving on to the next question. So since you must be seeing a lot of patients, I would like to ask you if you're seeing a difference in terms of the symptoms with people who are infected with Delta variant or Delta plus variant, and what does the global data say?
So I mentioned it in my slide, but we are seeing in the second wave a little difference in the presentation. So we are seeing more and more GI presentations where they come with diarrhea for a few days, or maybe just 1 day or 1 week, may not come with cough. We also see patients who come very critical with a diabetic ketoacidosis. They may present as a stroke, they may present as myocarditis or a heart problem, and so on and so forth. So there are varied presentations. We cannot exactly pinpoint and say that this is all because of the Delta variant, but yeah, more or less looks like, because the second wave, 90% as per at least one study, was the Delta variant.
Sure, sir.
We also saw it happening in the younger age group. So the first wave saw it in the elderly group, and the second wave saw it in the middle age group and young patients. And therefore, there was a lot of hue and cry about the third wave affecting the children. And therefore, at least in Maharashtra, we made a separate task force under the Honorable CM's leadership. And we are well prepared, even if it may hopefully not affect the pediatric age group.
So that brings me to the next question. Dr. Vijay says, please discuss the epidemiological indicators which favor for the third wave in India.
I am no one to predict this. There was a Kanpur model which said that yes, it would come up in October, November. Some people, some experts argue out that it's already been seen in Kerala and in some parts of India, and so on and so forth. So I don't think we should be following any model, a mathematical model of when it should come. and hopefully we can delay it if we increase our vaccination program and if we use COVID appropriate behavior. Now, when we start unlocking in most parts of India, we should be even more careful because that is the time when the spread can be much more, keeping in mind that the Delta virus or the variant has a transmissibility of about 60 to 70% more than any other.
Correct. So that brings me to the last question. A doctor wants to know, does the concept of home and hospital treatment change with the Delta variant?
So home quarantine and treatment has come a long way. We have realized initially that it was very useful because the hospital beds would definitely be relieved and they would be kept only for the critically or the moderately ill patients of COVID. And also we would have the beds available in the hospitals to do the non-COVID work, like patients in emergencies of medical and surgical origin, which also need to be tackled even if they have not got COVID. But along the way, we realized in some districts in Maharashtra and elsewhere that home quarantine was not done properly. And because of the Delta variant, if one person had it, all the family members definitely got it and got transmitted because of its transmissibility being high. And therefore, there was a question raised, and many districts, we have even mentioned to them that they should not be doing home quarantine. Whichever strategy you use, be very potent in what you are doing, and please be backed up with evidence and science, because just giving a patient multiple medications at home like ivermectin, and I see prescriptions with 3 antibiotics and so many drugs which are supposed to be antivirals, and that creates a lot of harm. So whenever some patient is referred to me like this, my job is only to strike off whatever is not needed, and I'll end up with nothing but just giving them proper advice.
That's great, sir. So on that note, any takeaway home message for our audience, especially for our frontline workers?
Yeah, so please, the frontline workers are risking their lives. They're not even meeting their parents and families for days on end. So kudos to all our healthcare worker colleagues. Please be safe. Always wear your PPEs and your masks, and do not lower your guard even when you are in a little relaxed atmosphere. But also to all the public, please get vaccinated. Throw away the vaccine hesitancy and pick up your masks. And that's what I would say. And do not worry about the variant. There was a lot of scare in the last 3 months that they have an immune escape and therefore the vaccines will not be useful. But evolving data is showing that it definitely prevents hospitalization and definitely prevents death. And therefore, that's what we want.
Thank you so much, sir. That would be all. Thank you for answering all the questions so well and sharing your insights today. It was a very enlightening session with you. We are very grateful to you for your time and valuable suggestions. For our viewers, I hope you guys had a great time watching us live. Feel free to post more questions and we shall get back to you on that. Thank you for joining us today and making the session so interactive. We will be back with another such clinically enriching discussion very soon. Until then, please take care and have a great Sunday evening. Thank you so much, sir.
Thank you, Darshika. Thank you, Docplexus. And thank you all for sparing your time on a Sunday. And let's make it a little safer place and try to fight this demon with all we have. And we can't be holding hands, but we should at least rub our hands together just on ourselves and wear the mask. Thank you.
Thank you.
Be safe.
Good evening, sir. Thank you so much.